My name is Dr. Wayne Terrace, and I'm the Chief Medical Officer at Care Compass Network. Welcome to the first annual Partnering for a Resilient Community virtual learning. The 5 W's, who, what, where, when, and why of Trauma-Informed Care webinar is sponsored and supported by the Care Compass Network's Regional Trauma-Informed Care Network team. The team consists of dedicated and passionate individuals from colleges, county government, healthcare, social care, human services, and schools, spanning across Care Compass Network's 9-county region in the Southern Tier and beyond. The team envisions a resilient community built upon strong partnerships, trust, and compassion. The Regional Trauma-Informed Care mission is to implement evidence-based, trauma-informed care by supporting the development of resilient and strong partnerships, individuals, families, and communities through advocacy, education, and empowerment. A core strategy to bring this to fruition is to create and promote access, availability of training, educational tools, and resources for our community. Before we start the presentation today, I would like to go over a few housekeeping items. Today's presentation will be recorded for quality assurance purposes and may be uploaded to CCN's website or YouTube page. We are reserving the last 10 minutes for Q&A. Please type your questions into the question and answer box, which is located on the bottom of your screen, and you can send in your questions at any time. Now I'd like to introduce our presenters. First, Dr. Maxfield. Having a long-standing curiosity for the mechanistic backgrounds of societal health issues, Dr. Erin Maxfield completed her post-secondary study at the University of Texas at Arlington and earned an honors bachelor degree in chemistry. After, she matriculated into Lake Erie College of Osteopathic Medicine, where she spent her entire clinical years in the Southern Tier of New York, working exclusively with underserved patients. After earning her medical doctorate in 2016, she took a position as a postdoctoral research scholar at the prestigious Case Western Reserve University School of Medicine in Cleveland, Ohio, studying novel pharmacologic interventions for Alzheimer's disease. Her work as a co-investigator led to multiple peer-reviewed publications and culminated in FDA approval for a multi-site phase 1 human clinical trial, which is currently ongoing. Additionally, while engaging in research, Dr. Maxfield served as IQ curriculum adjunct faculty at the Case Western Reserve University School of Medicine, teaching second-year medical students neurology and psychiatry. Upon completing her time in Cleveland, Dr. Maxfield returned to the Southern Tier of New York to start her postgraduate medical intern year at Arnold Ogden Medical Center in Elmira, New York. After completing her first year, she transferred to Our Lady of Lourdes Hospital in Binghamton, where she is currently completing the remainder of her residency in family medicine. During residency, she has served on the ethics committees of both respective hospitals. After completion of residency, Dr. Maxfield intends to remain committed to integrative primary care, evidence-based management of neuropsychiatric disorders in the primary care setting, clinical research and design of clinical trials, and empowering underserved and vulnerable patient populations. Next, Dr. Lavin. Dr. Michael Lavin has dedicated over the past 25 years to better serve the needs of people with mental health and substance use disorders, especially in the underserved rural areas. He has worked in both inpatient and outpatient mental health settings, helping diverse patient populations, ranging in age from youth through the elderly. He is an advocate for the integration of behavioral health and primary care initiative and has supported the evidence-based collaborative care model at Our Lady of Lourdes Hospital as they seek to embed mental health services in a variety of their primary care sites. He also enjoys teaching a variety of students, including family practice residents, medical students, social work interns, psychology interns, and nurse practitioner students. Another emerging area of interest has involved the use of the recovery model and provider burnout. Dr. Lavin has also served as Care Compass Network's District 3 AI project lead, clinical governance committee, and as chair of the CCN Regional Trauma-Informed Care Network, which has worked to develop and promote evidence-based trainings, tools to support the implementation of trauma-informed care, and resilience across the care settings. Dr. Lavin earned his Doctor of Medicine degree from SUNY Health Science Center in Brooklyn, New York, and completed his residency at Hillside Hospital in Glen Oaks, New York. He is board certified in psychiatry and addiction psychiatry. Dr. Lavin currently serves as Director of Psychiatry at Our Lady of Lourdes Hospital in Binghamton. So with that, I'll turn it over to Dr. Maxfield and Dr. Lavin for the presentation.
Thank you, Dr. Terrace. I am going to start today and welcome everybody. It is a great pleasure to be here, and my hat really goes off to the folks at CCN, including Dr. Terrace, Bukam Rossetti, and a tremendous team that has been working on the trauma-informed care and concerns around that. And I wanted to start off because Dr. Terrace asked a very pertinent question in terms of COVID at the end of the last session with Dr. Brown, and I know a fair number of people are tuning in. And I thought it was a really very pertinent question because we find ourselves now in the midst of a perfect storm. And what I mean by that is this has been a very different kind of time. We find ourselves isolating a lot more. There's tremendous stress out there financially for many, and now children are spending a lot more time at home. There's more stress on parents. There's financial stressors. There's substance use, domestic violence, and really a tsunami of trauma that we're finding ourselves about to face and facing currently. At the same time, many of us as providers are facing our own challenges. We are now spending most of our time wearing masks and visors, and these make it harder to connect. And a lot of our folks are not feeling very safe in terms of coming in. And we're still dealing with a lot of other stress. We have a great difficulty in terms of time constraints, having to fill out endless paperwork, use EHRs that are not particularly user-friendly. And so our job really has gotten harder and harder. Unfortunately, the focus by the powers that be and in general the science has been about flattening the curve. And the main proponent here, or the main concept, has been social isolation. And it's really unfortunate that the mental health implications of what we're going through hasn't really taken the primary thought process or really been taken into account. So all of this, just to get to the bottom line, to me makes today that much more relevant. My hats really goes off to Dr. Maxfield. I think she was incredibly, had a lot of forethought and really is a pioneer in terms of our local programming here, in terms of how to do something more in terms of trauma-informed care in the primary care site. So I'd like to hand it off to her, and I will jump in where appropriate.
Thank you, Dr. Lavin. I just want to mention I had the pleasure of meeting Dr. Lavin about a year ago through an elective psychiatry rotation here in Binghamton, New York. I found that he was as committed to evidence-based integrative primary care and especially trauma-informed care as I was. It's been a delight working with him, especially on this project. Next slide, please. So I want to share with you how to implement trauma-informed care into your practice using our successful pilot as a model. Who are the players in our story? Next slide, please. They consist of 6 family medicine residents of the 2021 class, of which I belong, and our respective adult patients in our resident continuity clinic. The entire clinic nursing and support staff, Dr. Lavin, social workers and health coaches from Lourdes Youth and Family Services, Care Compass Network, Regional Trauma Informed Care Network, and the Mother Cabrini Foundation. Next slide, please. So at this point, I'll let Dr. Lavin touch on what exactly is trauma.
So I'll just put a plug in. The CCN Regional Trauma Informed Care team is working on a toolkit, and that is coming very soon in terms of helping schools and providers in terms of how to address these areas. But in particular, when we're talking about trauma, this can mean something very different to different people. And so there's really a whole host of things that come to mind. It can also be just a single event or a recurrent series of events, which is probably more common in terms of what we see. I have to tell you, in my role at Lord Center for Mental Health, I sign off on treatment plans, and it is amazing to me, and has been, the amount of folks that are dealing with trauma and post-traumatic stress disorder. But this slide gives you the kind of things that are out there, ranging from abuse and in-home traumas, neglect, and community-wide traumas. By history, I think a lot of us think about trauma in terms of the war setting and veterans, but this can occur in a whole host of ways and places. And I'm not going to read all of the slide, but I think this gives you some of the key ones. I wanted to introduce fairly early on a concept of toxic stress, because that's something you may hear about. Toxic stress is experiencing trauma in the absence of supportive adult relationships and other supports. And so it's not just about the trauma, but the aftermath of that and the ability to cope with it. So we can go on to the next slide.
Okay.
So this will be our first audience poll question, and it refers to trauma being defined by the landmark CDC Kaiser Permanente study, and how many possible types that should be identified by clinicians. The Kaiser Permanente study took place between 1995 and 1997. And so if you're feeling like you're late to the game in terms of this area, please don't think that, because there's a real lag in terms of what we've known about ACEs and the adoption of screening and other things in the clinical world. So the options here, to get back to the question, are number 1, 10, number 2, 2, number 3 should be 6, number 4, 4, and number 5, other response. I'll give a few seconds. We have the tally. Okay, so the majority are saying 10 items, and that is the correct answer. We can move on to the next slide. In fact, there were 10 specific ACEs that were asked about in the Kaiser Permanente study. And you can kind of sort these into 3 domains, 2 of which kind of have direct effects on the person, and the third, the household dysfunction, a little bit more indirect. But this really underscores, I think, the need that's out there to screen and to ask folks in a sensitive way about what kind of history they may have experienced. And we're going to get into numbers in a few minutes. But you can see here, you know, some of this may be intuitive to you. Some of it may be not so obvious in terms of having effects on people, and longstanding effects for that matter, as well as different kinds of effects. And we're going to see that play out. I just wanted to say the purpose of the poll questions is really to try to get some interaction, because I'm at a distance from you. And I know Dr. Maxfield and myself would love to have more interaction. So if we trigger some questions, please feel free at the end to raise them, and we'd love to have discussion, or even if you just have some insights, please feel free. So why don't we move on to the next audience poll question. And this one states that ACEs were not found in the following socioeconomic groups: those with median household income greater than $95,000 per year, Caucasian Americans who held a master's degree or higher, Asian Americans who attained at least a bachelor's degree and grew up in a two-parent home, physicians who successfully were in practice for more than 15 years, all of the above, or other response. And we'll give a few seconds to have you weigh in. I know we have a fairly large group, so we're giving everyone a chance to put an answer, and we'll discuss it. Okay, so the correct answer was other response, and again, the majority noted that, and there was a bit of answers all across the board. And I think the point of this question was that socioeconomic factors may not really be key in terms of experiencing trauma and adverse ACEs. And I think it's important to, again, not have any preconceptions here in terms of who may have experienced trauma and who may not have. In fact, I think we're going to see trauma is fairly common. Let's move on to the next slide. So what is the national prevalence? According to the CDC in 2019, a survey results across 23 states, more than half of adults, 61%, reported experiencing one ACE or one trauma during their childhood. And Dr. Brown just talked about a survey that she noted in the pediatrics world where they were measuring actually at the moment or in time, and it was 48% of US children in that study. 61% at least one ACE, and if you look at 3 or more ACEs, you're talking about 25%. So these childhood traumas are not unusual, unfortunately. And in the little blurb there, it says adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. So I think the case is made here, and I think intuitively we kind of know this, that trauma is ubiquitous, and it's not always obvious in terms of people that have been through this or are still dealing with it. And it's really important to keep in mind. So we'll go on to the next slide, and I think Dr. Maxfield is going to pick it up from there.
So building on that, researchers at UC Davis Medical School in 2019 found that the prevalence of ACEs in third-year medical students was comparable to rates in the general population. And to me, that's kind of shocking, and it's kind of counterintuitive, because especially with maybe the older social determinants of health model, where for right or wrong, a lot of providers and a lot of people in the lay public kind of associate negative health outcomes with poverty or low education. Here we're seeing that 61% of medical students have an ACE score of 1 and 25% have an ACE score of 3 or higher, which means that healthcare workers have a prevalence of ACEs as high as their patients.
Do you think, Dr. Maxfield, this could be a discussion for later, but I wonder if some providers seek out healthcare careers as a way to kind of cope or make up for perhaps the kind of traumas they've gone through themselves. Maybe it's a sign of, resiliency for them. But perhaps
it might be. And I heard a quote from Dr. Nadine Burke-Harris, who's the current Surgeon General of California, where she was speculating that, maybe the opposite is true. People, most Americans right now have ACE scores, and so they do what they can to try to think of themselves as not being part of those people who have been traumatized and try to ignore it.
Mm-hmm. Yeah.
Next slide, please. So we're going to have our poll question number 3, clinical treatment of ACEs in the primary care setting consists of the following: referral to psychiatry, medication prescribed in the primary care setting. Answer choice 3, very high ACEs are refractory to treatment, so it's up to healthcare workers to be adaptable to the needs of patients and be long-suffering during all patient outbursts. Number 4, all the above or other response. Dr. Lavin, do you want to provide the explanation?
Yeah, I think we were hoping to say with this slide was that resiliency building, which we think is very critical to helping folks move forward in terms of having high rates of trauma, really does not have to involve providing mental health care. It could, but our concern is that cases not simply be referred on to someone else, but that people try to be helped in the setting where they are. And primary care makes a lot of sense. So we don't particularly think that referral to psychiatry is necessary. We could certainly see cases where it would be. We don't think it's necessarily a medication issue either. So I don't know if this was a little bit of a tough question for the audience, but I think
we made it tricky for them.
Yeah, I think what we were trying to point out is that we in the healthcare world want to be able to develop more of a competency to help these folks and not just say, go over there and deal with it.
Yeah. And then for ACEs, the antidote to that is resilience building. There is a potential treatment. That's the whole purpose of these workshops today. It's not a futile cause. You don't just have to give up and say that, oh, the patient is just going to be that way forever. And then very quickly, Dr. Lavin, could you kind of explain the difference between resilience building and mental health care?
Yeah, I think we're going to talk a little more, I think, about the kinds of things that go into resilience, which we all have innately. That's good news. Mental health care, though, is specifically targeting the loss of function due to specific mental health diagnoses. So experiencing trauma doesn't necessarily lead to a mental health diagnosis. So it's kind of two different things in a sense. It could, but in a majority of cases, I don't think it necessarily does. So what we're trying to do in terms of resiliency building is, picking out a bunch of concepts, including the recovery model that was mentioned before. And I think that's really the nature of trauma-informed care, trying to build resiliency and offer something else in addition to that. And I don't want to jump ahead in terms of slides, but we're going to go over that in just a minute. Should we move forward?
Yes.
Okay.
Okay. So as we already just mentioned, the only proven antidote in literature for personal trauma, adverse childhood experiences is resilience building. This happens at an individual level. When an individual, however, decides to become a healthcare provider, they are no longer operating on the individual level. You now are involving other people into your sphere of influence. And so in that situation, you're held to a higher standard. You're not only expected to have your own personal resilience, but the ability to employ trauma-informed care. Next slide, please. Very simply, the definition of trauma-informed care is resilience and empathy. Resilience is gleaned at the individual level, And then empathy is the ability to understand and share the feelings of others. And that opens the window for rapport that you build with your patients, with your colleagues, and be able to share the wisdom of the resilience building skills that you have learned with them. It's not possible to teach somebody how to be resilient if you've not done that yourself. Next slide, please. So when successful, the recipient of your trauma-informed care, again, whether it's your colleague, your student, your resident, your patient, should feel the presence of the following 5 qualities: safety, choice, collaboration, trustworthiness, and feeling empowered by you. The significance of these 5 qualities is that the opposite of each of these things is abuse. Most healthcare providers would be horrified to think that they are potentially abusing patients or re-traumatizing patients, colleagues, others. But that's the risk you take when you don't employ trauma-informed care into your daily practice. Next slide, please. So if a program in real life sought to implement trauma-informed care into their practice, how would it be done? I'll tell you. First, we started with the staff. So myself, Bucam Rossetti from Care Compass Network, and Joe Alford from Lord's Youth and Family Services created a bunch of series of interactive Zoom sessions for the entire resident continuity clinic staff and personnel. We went over the background and biology of ACEs, resilience building. We provided them strategies when interacting with patients in the moment on how to center themselves, bring resilience into their daily life, and be more empathetic. We tailored it to their background, their educational level, and their job duties.
So if I could ask a quick question of you, Dr. Maxfield,
Sure.
and I'm thinking if I'm in the audience and I'm interested in implementing something like this, will you be able to share what those trainings were composed of, or maybe talk about where did you find material to try to provide this for folks?
Sure, and some of the material that we used, I will be referencing in later slides, but yes, I'm open to doing that. Next slide, please. Then after we started with the clinic staff, I shifted my focus to physicians. I created a unique intensive curriculum of resilience and empathy building for select, currently now PGY3 residents from my class. The individuals who I chose to be part of this program had demonstrated an interest, natural proclivity in trauma-informed care and resilience building higher than their class peers. Next slide, please. In the curriculum I designed for myself and the other 5 residents, resilience and empathy were emphasized, obviously, because that is the definition of trauma-informed care. I drew from world-renowned leaders in the science of resilience and empathy building, including Karen Rivich, who's the current director of the University of Pennsylvania Positive Psychology Center, the UC Berkeley Greater Good Science Center, and then Dr. Tanya Singer, who is the director of the Max Planck Institute of Human Cognitive and Brain Sciences in Germany. Based on the research from Dr. Singer and her clinical trials, meditation was an integral part of our private curriculum. We learned that there are 3 major forms of meditative practice today: affect, presence, and perspective. All 3 of them build resilience, but affect meditation in particular strengthens the brain's right cortical areas from the insula to the temporal lobe, which are the empathy centers of the brain. So if you employ that sort of meditation daily over a long period of time, you're literally working the brain's muscle to be able to perform empathy better than your peers. Next slide, please. Other activities that we were involved in were different modalities that in the literature have been shown to boost resilience, such as expressive African drum therapy. They lower the levels of cortisol in the body. They improve immune function. We found a local instructor. We had several sessions. The bottom picture, actually, when we were in a park that just happened to be on Juneteenth, but that was a wonderful experience and we enjoyed it greatly. Next slide, please. Besides their structured activities, we also had informal check-ins. This is our group. I want to say thank you to all of them for being wonderful colleagues and great role models, both for their patients and for their peers and the community as well.
Would you like to mention them by name? Would you like to mention them by name?
Oh, yes. So starting from left to right, Dr. Yahya Azam, Dr. Benjamin Forbes, Dr. Chris Somsick, Dr. Leslie Jones, myself, and then Dr. Christine Fang. Thank you, guys. All right, next slide, please. All right, other structured activities that we incorporated were trauma-informed yoga, different workshops with a local licensed visual art therapist. And then something that I didn't include in the pictures on this slide, I organized a in-person workshop where we had standardized patients for the 6 of us. The standardized patients were chosen and created a situation that's very realistic and very reflective of patient encounters that we've had in our clinic with patients who've been shown to have high ACE scores. We also practiced screening on the standardized patients for adverse childhood experiences and building that rapport to allow the patients to want to engage in screening. It's my and Dr. Lavin's hope that my curriculum, something along those lines, could be adopted by other residency programs besides ours, and that obviously we would continue here at Lourdes and Ascension Health Family Medicine Residency Program in allowing the younger residents to also be a part of this and to kind of carry the torch going forward in this topic. Next slide.
I am impressed in terms of the amount of effort and time that went into this. What would you say to folks maybe in terms of that time aspect? Because I know how busy residents are. Was it difficult to make the time to do these kinds of activities?
Well, because these activities were resilience building, even designing the activities to an extent were for a good reason and a useful purpose. It's no different than residents who make time for going to the gym or at least having a few dinners per week with their significant others and their families. So if it's important to you, it's easy to make time for it. And I don't think that it was an unbearably large amount of time. I think it's doable. I have the luxury of not being weighed down currently with family or other responsibilities, so I did have some time, maybe more than other residents had, to do this.
I was just thinking, if I was a busy, if I was a residency director, say, how would I factor in this amount of time that's going to be needed to get these kinds of things done? And again, we can have discussion more later. Maybe Dr. Welch would like to kind of talk about that later on, or what kind of thoughts would go into his mind in terms of how to factor in these kind of different activities.
Okay, next slide, please. So to quantitatively gauge the impact of the trainings on the staff and the physicians, I administered the National Council for Behavioral Health's organizational self-assessment, their TIPSY OSA. The OSA is a performance improvement resource to engage primary care practices in self-reflection to gauge their readiness to implement trauma-informed care. Results from our analysis showed a statistically significant impact on our staff and physicians after the series of trainings. Next slide, please. Then to gauge the impact of my unique curriculum on the 6 residents, including myself, and ultimately on our patients, We administered the guide for using the trauma-informed practice tip scale by Sullivan, Goodman, Jennifer Fauci, and others. I shortened it somewhat to make it more user-friendly for our particular patient population and to fit within the constraints of a standard office visit, but it was based on that document. And our final data analysis is currently pending on the results of this.
Would you like to say a few words about what's under the pin there in terms of characteristics of a trauma-informed primary care practice in particular?
Sure. So this document basically becomes a satisfaction survey for patients. And what satisfaction we're trying to ascertain is if the patients feel that we are treating them and handling them in a trauma-informed care way. And again, are we treating those patients using those 5 qualities that we saw on the earlier slide? A culture of safety, collaboration, trust, empowerment. We also use some terminology asking if the patients felt that their unique cultural backgrounds were respected in this clinic, if the patients felt that the physician and the other staff at the clinic understood what it meant to be in their financial situation, and asking if the clinic and physicians as a whole support the patients and are making them feel more empowered to live their lives and to strengthen their relationships in the community and with their family and children. Okay, next slide. The workflow that we used in this research pilot was gleaned from a workflow propagated by ACEs Aware. ACEs Aware is an initiative led by the Office of the California Surgeon General, who is currently Nadine Burke-Harris, and the Department of Healthcare Services there. Okay.
I see some G codes at the bottom there in terms of billing.
Yeah, that currently is, to my knowledge, something that's being done in California. We are in New York, obviously. We were not aware of any ICD codes that we could currently use in our clinic to document screening that was done on patients. Next slide, please. We also were very mindful in creating our workflow of the toxic stress risk assessment algorithm that ACEs Aware also put forth. And basically the take-home message of this slide is that all patients who have an ACE score need to be educated on resilience and linked up to services that can provide more in-depth education and or services related to resilience as needed. As your score, and here's the second take-home point of the slide, as your score approaches 3 or higher, you are entering into the high risk zone of having associated health conditions. Based on our particular patient population, their extensive medical comorbidities, their rates of compliance, their compliance with medication, compliance with keeping follow-up appointments, we anticipated that our patients that we would be screening would have a high ACE score of at least 3 or higher. Okay, next slide, please.
So I'll weigh in here. This is the actual form I believe you were using with the 10 items that were noted. And I think one thing to note on there, you don't see patient's name or date of birth. These were actually de-identified because there were concerns, would this cause more harm in a sense for people having to reveal specifically what the ACE or trauma was for them. So I think that was being very sensitive. And I think the key takeaway for home is, we're not really necessarily concerned about what the actual trauma was, at least at the beginning. We just want to get a handle on how many traumatic events you've experienced.
Right. And this questionnaire was a little bit different, I believe, than the questionnaire that Dr. Brown had used in her clinic. This also comes from ACEs Aware. The language of it doesn't specifically indicate racial discrimination or institutional racism. However, in the first question where it asks, did you feel like you had no one to protect you? That could include that feeling. Again, it would have to depend on the patient, how they interpreted that. But I just wanted to point that out.
Yep.
Next slide, please. Okay, so as anticipated, after several months of screening our patients, the vast majority of them, now these are the patients of myself and my other 5 colleagues, we made follow-up such that these patients would only be exposed to us during the months that we screened them, because the theory was if we had extra training and empathy and resilience building and trauma-informed care, we wanted to see how that may impact those patients. We didn't want to expose them just yet to other residents who did not have this training. However, at the end of the screening period, we found that the majority of our patients did indeed have an ACE score of 3 or higher with associated health conditions. Okay, next slide, please. So, based on the algorithm we saw earlier, okay, we've identified patients who have high ACE scores. We need to educate them and provide them services. But how are we going to do that? Well, fortuitously, Lord's Youth and Family Services were awarded a very sizable grant from the Cabrini Foundation. And the stated goal within that grant completely aligned with ours. Through this grant money, we were able to provide our patients, the 6 of us residents, our patients on-site health coaches for physician warm handoffs. These health coaches were provided free, at no charge to the patient. Other small little modifications to our clinic included during the very hot summer months, getting a refrigerator for our front lobby area that were stocked with cold bottles of water, and that was very, very wonderful for our patients who had to walk to their appointments or ride in on bicycles. They greatly appreciated that. There were other in-person services planned for our patients to build their resilience, activities similar to the activities that we residents engaged in. However, due to the COVID-19 pandemic restrictions, a lot of it had to be delayed and was not able to start just yet. Next slide, please.
So I think you're getting at some of the key concerns in terms of, why screen if I don't know what to do when I find positive results. And I think you're saying here, the timing with the Cabrini grant and these other things I think you're going to talk about really do help the provider in terms of what to do next.
Sure. Yeah, they make all the world of difference. And again, it was just good fortune that it happened at the same time that we had our project. Because a lot of the in-person services were delayed due to the COVID-19 pandemic restrictions, we residents passed out to our patients handouts providing vetted, reputable virtual resources that promoted different types of wellness for them free of charge.
I don't see a pill for resiliency on there.
No. Next slide, please. So where did this happen? Next slide. This is our resident continuity clinic at 303 Main Street. We are in Broome County of upstate New York in the southern tier. Next slide, please. Just some quick facts about our clinic. We see over 11,000 patients yearly. The majority of our patients are 18 years or older. And that's why we were screening for adults. In Dr. Brown's talk, she's a pediatrician, obviously, screening children mostly. The screening tool that we obtained from ACEs Aware was specifically scientifically validated for English-speaking adults. There is another questionnaire one can use. It's on ACEs Aware's website for children, and it's called PEARLS. But in our clinic, we have up to a 30% average no-show rate. Again, it's just due to the nature of our patients having very high ACE scores. In Broome County as a whole, the majority of people here have no higher than a high school education, and we are above the national average in poverty rate. But again, these two things, education and income, are not required to have high ACE scores. Okay, next slide, please. Okay, so when did all this happen? Next slide. It happened right at the start of the original COVID-19 pandemic. So in March of this year is when we began the staff training at our clinic. That went until July. And then in March, we started the resident physician training, and that ended in June. We went go live, the 6 of us, with adult universal ACE screening this July. That's going to continue until we are no longer here, into next year. Okay, next slide, please. Our hope is that there are younger residents currently right now amongst us who are very interested and highly motivated in trauma-informed care and are interested in becoming champions of this cause and kind of taking the torch for the future, and kind of truly changing the culture in our clinic to make sure that we are treating our patients with trauma-informed care. We are making screening of ACEs a commonplace issue, as common as PHQ-9 screening or GAD-7 screening. And we have faith that there will be residents who are also very passionate about this subject too.
Yeah, so I think this is your advertisement for folks that are in earlier years of training. If they have an interest, they could certainly pick this up, or there's a number of variations that they could look at. And I know I would be happy to help if I can. And one of the things Dr. Brown mentioned was really the challenges in screening. And I think we saw that in Bucom. I think we'll probably comment on the barriers to trying to implement these kinds of things. And I know it really helps at all levels, especially, from the program director level, from the upper administration levels, to have that support to really change culture, which my hat goes off to you for the effort you made here. I think, it's pretty straightforward the way you're presenting it, but I think it had to have been really challenging at times, and I'm pleased that you continue to persevere. I think your own resiliency level must be quite high.
It's all the meditation we did, the 6 of us. Thank you.
Okay.
Next slide, please. Okay, so why are we wanting to do this? This is our last poll question for today. The single biggest reason why a primary care physician should be well-versed in ACEs is because it increases reimbursement, it's good public relations, it fills the gap in the shortage of psychiatrists, it's the single greatest unaddressed public health threat in the US today, all of the above, or other response.
We should have put in music like from Jeopardy. All right, so the answer, and I'm glad it sounds like people were really in tune with this. It's that it's the greatest single unaddressed public health threat in the US today. If we move on to the next slide.
Oh, there it is again.
Yep, I think we noted that earlier. So we can move on to the next slide for the sake of time here. So I think if you were tuning into Dr. Brown's, this is a well-known slide in the ACEs world, looking at the pyramid, kind of starting from the bottom, that historical trauma and generational issues. I think she referenced racism, poverty, so on and so on, and then moving all the way up towards death and mortality and morbidity. And it's what's in between that still needs some working out. I think we have some sense of biology in terms of adrenaline, fight, flight, for example, or changes in brain structures. But I think we still have some work to do in terms of understanding these changes. And I made a note to myself to say, you know, as the ACE number increases, so does the death toll. I think, you know, another kind of way of looking at this that I've been thinking about is if you consider, you know, the concepts of a stream, and sometimes people talk about upstream and downstream. And so if upstream is kind of at the bottom here in terms of conception, and then, you know, where most of us finds ourselves are kind of in the trenches, you know, and dealing with a lot of diseases later in the game. I think that would be toward the top of this pyramid. And I think none of us, you know, ever are really totally satisfied. I'll talk for myself at least. I feel like there's always something more I wish I could do. And when you see no-show rates, you know, that all of us have that are pretty significant, it feels like something's missing. And I have to wonder, you know, to what extent, or is this a kind of key ingredient that we're missing, this idea of trauma. And so, again, you know, I think this is a timely talk to begin with, but even more so, I think whatever time someone in the audience wants to put into this, I think it would be well worth that time in terms of being more effective at what we do. If we go on to the next slide. Targeting ACEs could really reduce some of the most widespread health conditions faced in the United States. And I can't tell you all the details of how, but practicing in this trauma-informed way, it's felt could help, you know, lessen some of these because we're looking, you know, at really, you know, high rates of depression, heart disease, obesity. And we could really reduce these if we could practice in a different sort of way and engage people. I think sometimes people don't show up or don't follow up because they don't feel like they got what they wanted or what was helpful to them.
And they felt re-traumatized during their visit.
Absolutely, I totally agree. And so, you know, first, we don't want to do any harm, right? That's the oath we took. And we really want to kind of pay attention to the way we're interacting. And my heart goes out to all of us because I think we all have challenges, whether it's time or, you know, the EHR or whatever new initiatives or paperwork. I think it's a real challenge for all of us every day. Let's move on to the next slide. So I think Dr. Maxfield is going to pick this one up.
No, it's just expanding on the previous slide that these are conditions that are so widespread right now in the United States. These are estimates on how we could reduce those total numbers of patients with these conditions if we targeted ACEs. And this is not, again, you know, just a mental health issue. These are all medical problems that we see in a primary care setting. So it should be very natural for family medicine, internal medicine, to want to screen for ACEs because these are the conditions that they see. It's not a psychiatric issue, not a social work issue. It's just their bread and butter cases that could be improved.
That's a really good point. I think on the next slide, we're going to talk about socioeconomic challenges. And, one of the talking points these days, or one of the interests, is this idea of social determinants of health. And the idea there, I think, is that regardless of whatever medical care, there's other aspects that really play into outcomes. And, socioeconomic challenges are, I think, a big portion of that. While we're living kind of downstream, I think these play a role, but they're even more maybe important upstream, in terms of what's coming before, the medical issues pile up and the morbidity and mortality set in. And
Right.
so ACEs, if we can target that, I think could be really helpful. Social determinants, Dr. Maxfield and I have talked about a little bit. I think of that almost in a more global or population level way. And I think those are, really important to focus on as well. I think ACEs, though, is a slightly different concept in terms of what we're looking at on an individual basis. But there's definitely an interaction there.
Yeah, there is some overlap. People who grow up around negative social situations, they will develop, when they become an adult, ACEs. And then people who have high ACE scores will go on to have negative societal outcomes. So there is some overlap, but with ACEs, it's unique because this event happens before the age of 18. And it's well documented in the literature. The Surgeon General of California, I keep referencing her because she's just a great champion, Dr. Brooke Harris, has noted that children are especially susceptible to repeated stress activation. Their brain structure and function, their immune system, their hormonal system, and even the way that DNA is read and transcribed are impacted. And that sort of long-lasting biological impact hasn't necessarily been shown in social determinants of health, because there are situations that fall under the umbrella of social determinants of health that are temporary, like not having transportation for a few months and things like that. And it's not quite been shown to have such a permanent biological effect that ACEs have. So I agree.
Next slide. So some of the ways of targeting ACEs could really reduce other widespread conditions like smoking and heavy drinking, and perhaps these maladaptive behaviors are some of those intervening steps that we just saw in that pyramid. But food for thought in terms of the audience. I wonder how much folks have tried to intervene with these kinds of situations and not been very successful, and how much did you happen to think about trauma as maybe a missing ingredient or missing link here in terms of trying to somehow be more effective in addressing these? Because I can talk for myself. I don't always think about trauma as that, and I think it may very well be. So we can move on to the next slide. I think Dr. Maxfield has that.
Yeah, this slide just reinforces that the only antidote for ACEs is resilience building, and that can encompass a lot of things, especially for different people. But the long story short is that resilience is not throwing a pill at a patient. It's not just simply ordering a cab for a patient and forgetting about them in other regards. And it's not using, a stern tone of voice when you're counseling them about their maladaptive lifestyle. If you go to the heart of the problem, which is a lack of resilience, and allow the patient to build their own resilience, they'll start taking care of themselves eventually. And you'll see that change in their health outcomes and in patient compliance and visits, medication compliance. Next slide, please.
Yes, so targeting ACEs could reduce the most widespread health conditions faced in primary care. We've seen that. Primary ACEs and or vicarious trauma, which is trauma that's experienced indirectly. And we're usually thinking about the providers in this case, treating their patients can lead to more trauma themselves. And one of the areas we're particularly interested in is burnout, especially among providers. And you have some of the key kind of takeaways here from a Medscape study in 2020 showing fairly high burnout rates. This is very concerning, and it's not exactly what you would think. If we start on the lower left there, which generation is most burned out? It's not the people necessarily that have been at this the longest. It's often the younger generations that are struggling. You know, in this study, 38 to 48% rates, while the boomers were more around that 39%. And that may be a little bit eye-opening for some folks. Maybe they didn't realize that. But burnout is a major issue that we're quite concerned about. And it's a significant issue when you look at severity of it. And then the question kind of below, does your workplace offer a program to reduce stress and or burnout? Maybe that's something the audience would like to weigh in on as well. But I think a lot of times it really doesn't. And I'll just point out that one item on the right there, that physicians have the highest suicide rate of any profession. Unfortunately, one doctor a day dies by suicide. And so we really have a crisis in many ways. And you know, we really need to do more in terms of burnout. Next slide. So I think we saw the slide earlier. I think this is just summarizing as we get to the end. Dr. Maxfield, would you like to say some final words in terms of closing us for today?
Well, I just want to thank everybody for being here and to really realize that ACEs are something that affects all of us. The majority of Americans have ACEs. And so we need to think of resilience building and trauma-informed care as not something that, we will affect and mask ourselves with when we go into the patient room. It should be truly a culture and a lifestyle choice and a way that we interact with not only our patients, our colleagues, our family, our friends, and everybody in our towns and our cities, because there is a huge problem right now in the United States.
I'd love to ask your colleagues or have them talk about their own experiences with engaging in your project. I'm kind of curious before we end if you could say, and we're going to take questions and hopefully have discussion, but I was kind of hoping you would maybe give a little feedback in terms of your own practice of medicine and maybe how it's changed having gone through this experience.
I know I've definitely had patients who I'm connecting better with, having broached the subject of ACEs and had them be willing to participate in screening. These are sometimes patients where I thought that I would maybe never be able to really connect with them, but it's allowed us to establish an even greater rapport. And I feel it's still a little early, since we've implemented this pilot project, but I feel that over the long term, their health outcomes, if we could measure, objectively, their health outcomes will drastically improve.
I would assume that's also good news for you in terms of your own personal satisfaction.
Yeah, it is very rewarding to see that and not to feel like, I don't know what to do. I feel like this is what we should be doing.
Yeah, I know a lot of times, we come up with treatment plans and people may not follow them. And we end up sometimes really taking that hard or taking it personal. We may even blame the patient. We'll say, that's a lousy patient. And the reality is it's probably not that at all. It's maybe more our inability to connect with them with this area in mind in particular today. So I don't have anything more to add. I think thank you. And I'd love to have discussion and questions.
Thank you, Dr. Lavin, Dr. Maxfield. I do have one question that came up. I'll read that off. There was an ACEs form that was called the Adverse Childhood Experience Questionnaire. Some of the questions could be very triggering to people with trauma history. What sort of safeguards were in place? For example, where the questionnaire was given, is there someone to talk about these experiences right away if the patient was triggered prior to exiting the clinic?
So that's a good question. Unlike in Dr. Brown's talk, the physicians administered the ACE questionnaires during the patient encounter. We, as part of our curriculum, had standardized patient practice opportunity before we started screening our patients with ACEs, where we kind of anticipated the worst reactions that might occur. The residents learned how to recognize different body cues, verbal cues, and kind of anticipate where the conversation would be had. But we wanted to do the screening as physicians so that we would have the resources to help the patient there if they were triggered, versus if we had just passed out these ACE questionnaires in the lobby while they were sitting in their chairs waiting for their appointment and had no resources around them.
Would you say a few words maybe about the other supports that were available to the resident doctors? Maybe the idea that you're working as a team, it's not just the doctor.
All the staff that went through the training, they were supportive of the project. The nurses, the MOAs. We have an on-site social worker who also was aware of what we were doing. She's been a good resource for us as well. And our cohort of 6 residents was kind of large enough so that on any given day in the clinic, there was probably at least one other of us 6 residents there for support amongst colleagues too.
So it didn't have to fall on one person necessarily if someone was triggered, say. By the way, did that happen during the course of your study?
To my knowledge, it did not. But who's to say what would happen in the future? I would like to think that being just observant and watching the patient in their reactions will be all that you need to stop and to halt a triggering process if it appears.
Okay.
Another question came through. What was the most significant barrier you encountered or are encountering implementing this initiative?
I would say cultural buy-in. When things have been in healthcare as a whole have been operating in one way, it's hard to change things in the beginning. At least in working with other residents, there have been times where we could see their stigma, for lack of a better word, and that was disheartening. Now, these were residents who were not part of our group. Hopefully, with our workshop today and then curriculum going forward, that would change. But that was disheartening to see. And we had to always kind of remind ourselves, well, this is just temporary. Hopefully in the future, they will be shown the light and they won't be in that, the state of stigma anymore. Other things regarding buy-in that were difficult was sometimes staff in our clinic would be just very overwhelmed for whatever reason, and short on time, where they can't step out and do a 1-minute meditation, or breathing exercise to kind of calm themselves and center themselves. And they wouldn't really share that they were going through a lot, and that may have manifested in their own personal frustrations, and they may have taken that out on other colleagues. So I would say that with the buy-in and changing a culture, it takes time, but as our original self-assessment surveys performed showed, we did have statistically significant impact on the staff, and that's reassuring. So knowing that if this continued and just having more of this in our culture, everybody would be in on this and have the buy-in and support each other.
You wanted to say a few seconds about the turnover in terms of staff during the time of your project?
Our clinic does have high staff turnover, and that has been shown to be affiliated with burnout. I feel that if trauma-informed care was a permanent part of our culture, that could definitely improve that. And our clinic is a wonderful clinic. It's not this horrible place, but this is just standard for many medical sites right now, because everybody has been operating in this non-trauma informed care way. So that would be one thing that would improve.
We have another question. Are patients with a score of 3 or 4 more likely to accept more help from community help or some community supports? Do you find that some have more difficulty with emotional regulation in the office? Next, do you find helping professionals like caseworkers, police, EMT, nurses, and physicians are guarded about ACEs?
The social worker, I'll answer the second one. The social worker in our clinic was aware previously of ACEs, and to my knowledge, she would from time to time screen. I don't know what is required of her now as part of screening. She was not directly part of our group. But yes, Dr. Nadine Burkhardt, she made the Surgeon General of California, she made a TED talk talking about the same thing about emotional regulation. The changes that impact the architecture of the brain affect the nucleus accumbens and the limbic system. And so these people do have more problems with emotional regulation. They're more prone to being offended, to being annoyed, to lashing out at providers and the staff. So yes, definitely.
I was kind of curious to kind of tag on to the last question. There was a question about, if you have 3 or 4 or more likely to accept help or community supports. Did you find that people maybe that had higher scores were tougher to engage in community supports or other sorts of help? Or is it just an individual kind of thing?
The problem isn't really, are they willing to accept it. The problem is it actually helping them? So I've had a lot of patients who had high ACE scores. They were connected with all these services. They had their cabs, they had their food assistance, this and that, and their health was still poor. They still had outbursts when they came to the clinic. They still, would using very colorful language, explain their level of respect for physicians and things like that. However, when you do start screening these patients for ACEs, as I said, just the act of asking them about their trauma is a form of empathy. And studies also have shown that just asking a patient about their trauma history, assuming you do it in a very respectful, trauma-informed way, is therapeutic in and of itself. So asking these patients increased my rapport with them, having the discussion about their trauma made our visits more impactful. And again, we are still in the early process of this pilot, but I think that in the future, definitely quantitative studies could be done showing the actual health outcomes and like improvement in their diabetes, improvement in their blood pressure, other things like that.
I think this also underscores your saying before that you'd like to see whatever services try to be offered in the primary care site. I think that was the goal with collaborative care, for example, that we would not only have the social worker, but a psychiatrist available to meet with the social worker and try to do as much as you can in the primary care site, and even have these extra supports, maybe try to be there as well, or at least meet the person where they're at there. I don't know if you want to say anything more about that.
No, definitely. And the health coaches that were provided by the grant from the Cabrini Foundation, it was our idea to have these health coaches physically in the clinic so that we can do the warm handoffs with the patients, because these patients have so much going on in their lives. They don't need another thing to think about. And again, even executive planning and Dr. Harris, Dr. Brown had said in her previous talk that the prefrontal cortex is affected when you have high ACEs. So just the act of having to plan something, to have to remember, to call, to make another appointment, it's just something they shouldn't have to deal with. And we really, really did appreciate the health coaches being present physically in our clinic.
Warm handoffs really make a big difference. I think our collaborative care social workers would say the same thing. I think it just gives a whole different feel to someone being asked to accept some additional help.
Yeah.
I have a very good question here. The attendee says, I would like to do more in this field. Today, I commit to doing more in our community. What would you suggest to anyone who wants to do more who is not a clinician or physician?
I would say the first thing you should do is to make sure that your level of resilience is as high as it could be.
And I'll just add on, Care Compass is a great resource. And if you have an interest, by all means, I would get in touch with Bucom, Rossetti, and we have a great team that's been working on trauma-informed care for a while now. And I think if there's a way to try to help, I think a good connection could happen there. But I think just having the interest goes such a long ways. And I think totally agree, Dr. Maxfield, to be aware of your own resiliency level and trying to build that up.
Yeah.
And really serving as a model for others.
Yeah, especially if you are not in healthcare, because as we saw, the majority of Americans have ACE scores. So there's always going to be somebody in your life, even if you're not a healthcare provider, who needs you to give them trauma-informed care.
I don't see any questions from the audience at this time. I'll just say that Dr. Lavin knows I share his passion and interest in regard to physician and clinician burnout. When I say physician burnout, it's not just physicians, obviously. It's everybody on the healthcare team. And this is a public health crisis. So what I find so gratifying about what you're doing here, it's a complete change in culture. You know, a few years ago when I was in training, you know, physicians had to be tough, had to internalize it. Reaching out for help was a stigma. And I'm so gratified to see that the culture is changing and that now we're heading in the direction that we need to. And, you know, also, as you know very well, if you, that pie chart that most of us have seen, only 20% of patient outcomes are from direct clinical interventions and 80% are social determinants, personal behaviors, all those sorts of issues. And I think that in the past, a lot of the source of burnout as an individual physician or clinician was trying to deal with this multiplicity of upstream issues without help. And now we recognize very well that you know, healthcare is a team sport, and we're bringing in these resources, and I think this will go a long way towards reducing burnout. Now, I know you did a survey pre and post. You know, we did a Maslow burnout inventory, a very objective measure of burnout a couple years ago through CCN throughout the 9 counties. Actually, I don't know, had you thought at any point or had you administered that sort of survey pre and post? I'd be very interested to see those results. I think I know what they'd be. But this is really cutting edge work. And I'll just end by saying there's 2 comments in here that I will echo. One is bravo, Dr. Maxfield, and I would echo that. And another comment is thank you for this. I've done work with families and community groups with very high ACEs scales, and your work on resilience is so inspiring, and I will echo that.
I thank you for the chance to interact. And Dr. Maxfield, again, my hat's off to you. I think you've done a tremendous job with this project. And I'm really hopeful that we'll have some other folks step up within Lourdes and help carry it forward. I think the Maslow is a very interesting idea in terms of, you know, looking at burnout. We didn't really do that in this project, but I could see that being yet another kind of spin-off here. So, well done.
Thank you. And thank you, Dr. Lavin. Thank you, Dr. Terrace. I'm very grateful also for Care Compass Network and Buchan Rossetti, everybody involved in this research pilot.
And if you decide to do the Maslow, we'll be very happy to help with that. You have some experience with that. So with that, we will end the discussion today. To the audience, you'll be receiving a short survey after the session. We would really appreciate your feedback. And on behalf of Care Compass and the Regional Trauma Informed Care Network, thanks for joining us and have a great evening.
Thank you.